Good morning to everybody. Keith, can you hear me?
Yes, sir.
Yeah, so Keith, we will be starting with the live cases. John Coppola and Sanjay Shah are ready to show a case which is going to be coronary plus renal, concurrent coronary and renal. And here we have our on-site moderators, Professor Fazila Malik and Professor Akasaka. And from 9 to 1 continuous we are going to have live cases. Professor Malcolm Bale will be, I have requested him to deliver his talk first after lunch, and even after lunch we are going to have a very exhaustive program. So sit back and relax, and we will be kicking off the second day of the program. Over to Fazila Malik and Professor Akasaka, and before that we will be delivering the history. Sunil Gurmukhani is going to deliver the history.
Good morning everyone. Today's first case is 73-year-old woman having history of resistant hypertension, presented with effort angina. Her stress test was positive, a normal LV function. Coronary angiogram showing significant disease in the LAD. And insignificant disease in the proximal part of RCA, and there is bilateral renal artery stenosis. Our plan is to fix LAD lesion and left renal artery stenting at present. Thank you.
Moderators for the first session are Dr. Tak Kwan, Dr. Mauricio Cohen, Dr. Samir Pancholi, Dr. Mir Jamaluddin, Dr. Jayesh Rawal, Dr. Tarun Madan, Dr. Ajay Mahajan, and Dr. Prakash Parikh.
Good morning, everyone. I'd like to thank the teachers for not getting teaching on the panel. That'll make my life a little bit easier. You know, it was 16 years ago that Dr. Kwan and I came to India and met Tejas Patel and Sanjay, and I think Sanjay is probably the finest interventionalist, finest radialist I've worked with. He came to St. Vincent's and spent a week with us back in 2005. And at that point, he really brought the lab into the radial world by teaching our fellows and our nurses how to perform this procedure. And it's really been an honor for me to work with Sanjay over the last 12 TRICOs that I've attended. Thank you very much, Sanjay.
So here we are taking conventional radial route because distal radial puncture will reduce our catheter length by almost 3 to 4 centimeter, because we are going to do renal artery with the right jerkin, which is 100 centimeter length. So sometimes length falls short in renal stenting. So to avoid that, we are using conventional radial puncture here.
I think left radial will be better idea rather than right radial, because
we are sure that we'll finish this case with right radial route. We have other option also that we are going to do, that we'll cut this sleeve. This sleeve is fillable, so that will also increase 3 centimeter more length. So I think we'll finish renal stenting with right radial route very easily.
Okay. I think the patient is not very tall, so it makes it easier.
Yes, short stature,
right,
relatively. Yes.
So John, I noticed that both renal arteries are compromised. So what made you choose, or what made the group choose the left over the right?
I believe the feeling was that the left looked to be angiographically tighter. I don't think that there was any physiologic testing if you're talking about renal vein sampling or
a captoprerenal scan.
Or renal scans, no. So it's just based on angiographic assessment.
Sanjay, Tak Kwan here. You do the conventional puncture. How, because you said that the distal you may lose a 2 to 3 centimeter.
Yes.
Right.
So why you don't puncture higher? And how safe we can puncture higher?
We are puncturing high, but looking at her short stature and this, we can cut that sleeve. I think we are sure that we'll reach with conventional right jerkin catheter to renal. Otherwise, we are making high puncture up to mid forearm.
Okay. I think that later on...
And in that case, we prefer left radial route, so that a little more length we can get.
I think later on when we go to do the renals, Sanjay is going to show you a trick that he taught me about 2 years ago in terms of extending the catheter length. Good.
So this is 6 French EBU for
six with 5.
so
You are using 6 with 5 for avoiding razor effect.
yes.
Is it your routine practice?
Yes, it is our routine practice and it's really helpful.
Okay. All right, Sanjay. Okay. Looks like I'm in the OV here. Okay.
What's the creatinine level? Is it normal?
Normal. Creatinine is normal.
This might be too.
Yes,
Okay, that's
very
good.
nice.
Okay. Good.
Epicranial or
I think an REO cranial will show this nicely, and then we'll do 1/4 shot.
Regarding the question of Professor Fazila Malik, she asked what is the creatinine level, and if the creatinine level is normal and there is bilateral renal arterial stenosis, whether can we keep her on conservative management without stenting to the left renal?
no.
I
Why?
think the pressure is not, they are unable to control the pressure with optimal medication. That's why they're considering the angioplasty.
That's right. Either blood pressure uncontrollable or repeated left ventricular failure.
Was fine.
Run through.
Given heparin, Sanjay?
Yes, heparin. Heparin.
You know, I think it's a bit controversial, but I think the woman has been on multiple drugs and still has poorly controlled hypertension. So that's the reason for trying to fix the renal arteries. I know right now in the United States this is full.
Straight.
Why don't you put a bend on it for me? So, you know, I believe the only class 1 indication now is for flash pulmonary edema in the presence of bilateral renal artery stenosis, but I think that a lot of us interventionalists sort of challenge that notion.
So what wire is this?
This is
Run
a
through.
run-through.
Run through. Extra floppy, run through.
Okay. If I wanted to get into that diagonal, I couldn't. Sanjay, can we get a different view, epicranial? I think this is coming off.
Epicranial. Epicranial.
Yeah, okay.
Vessel is also a bit tortuous.
John,
Yes.
you plan to do just one Y? You want to protect the diagonal or no?
I think that if you look at the REO crane tack, the lesion comes off after that diagonal, so we're not going to have to protect it.
The ostium of the diagonal is all right. There is
Yes,
no
the ostium of
significant.
the diagonal was fine,
So I think
and the lesion
do not
comes south
require
of the diagonal.
protection.
Well, I mean,
So I think our plan is to pre-dilate this.
0.5 by 15.
What do you want to take?
well,
it to
sometimes the
4.5?
angiographic, when you see the ostium,
Take it to
you don't
4.5.
see a lot.
Yeah.
So even though the angiographic is okay, we still sometimes have some trouble when we put a stent in the main branch.
Last run through.
I think that tack, when you look here at the
So you are not
there's
plan-
a landing zone. If I put my dot of the balloon just on the diagonal. My stent is going to be distal to that, and we should be fine.
So you are not trying to cross over.
No, I don't think there's a need to. I think that the disease starts after the diagonal.
Yes, below the diagonal.
So the plan is to do a gentle pre-dilatation.
At 2.515, sir?
There's a lot of calcium in the proximal part. You think you have a problem?
Certainly I hope not. I think that years ago there might have been a problem, but I think nowadays with second generation stents we should be okay.
The balloon went fairly easily.
Okay.
So this is 20 millimeter?
15. This
15?
is 15.
This is 15,
10.
fluoro safe?
Little down.
Okay, going to go down a little further.
Yes.
Okay. So this is a 15 millimeter balloon.
10.
Fluoro safe. This looks like a pretty good size. This is 2.5?
Yes. Or let us see.
Okay.
How does it
You
look?
want a little test there?
Yes.
All right.
Okay.
Happy?
Standard.
So what do you guys think stent length and diameter?
Running man.
So John, I would probably stand right distal to the origin of that diagonal. I don't think you have to jail it.
You know.
Right. You're saying stent distal to the origin or diagonal?
Correct, distal,
Yeah.
because I mean, I think you're going to get away unless you get, you know, a proximal edge dissection, but the origin of the
We can
diagonal
take one
is,
shoot to see the size.
yeah, it
Compare
seems
with
to
the
be
wire.
fine. I wouldn't say free of disease because all these vessels are so diffusely diseased.
Sitting?
And you can see the calcium there just proximal to the diagonal. And then there's another calcified non-obstructive lesion more proximally, and now you have a nice longitudinal non-obstructive dissection. So
Take 20.
you'll probably need a 20, I don't know
30 something.
Yeah, I was going to say 26, 28, but 30 would not be a bad idea either.
2.532.
2.532 is what we're going to be going with.
Good.
And I sort of have your plan to sort of put this just distal to that diagonal origin.
Yeah, it's amazing what the anatomy is here in this region of the world, because in the States you would not think about putting a 2.5 in the
Yeah.
mid-LAD.
Yeah, you look at
I
the
was thinking
atherosclerotic.
maybe 2.75. I mean, it's an LAD, right? Don't you think 2.5 might be a bit too small?
Well, I think if we deploy 2.5, let's say 14 atmospheres or so, we'll probably be around 2.6, so we should be pretty close. And then we're planning to do an OCT run, since we have a world's expert on OCT, to tell us how we did.
Yes.
Yeah, you got to make sure you seal that dissection, because you know, you can see the flap, so you see a little bit of contrast outside of the vessel.
Yes.
And then you see a little bit of flap just distal to that. So I think that a good long drug-eluting stent will cover that and will make it look like a new vessel.
You think the shadow is a dissection or just it was a calcium? It's not calcium, right? It was a calcium. Was it there before?
That was not there before, so I think it's dissection what you see outside of the vessel.
So then maybe hematoma developed.
Could be hematoma, yes.
Yeah, it looks like hematoma there.
Little bit.
Yeah.
Little bit.
Yeah.
We have plenty of
Yes.
length there.
We take shoot.
You want a little
Shoot.
test?
Yes.
You want me to sit this?
Sit. Looks okay.
This looks like a pretty good position, guys, right?
You can even go a little further if you want, but it's good.
We can
Well, if Sanjay's happy, I'm happy.
So it looks a little bit, I mean, it looks like you could get a little bit more diameter there. Maybe you may want to go to like 14, 16.
We're at 15. Is floor safe?
Okay.
Yeah.
John, we never go to 14, right?
Never go to 14. It has to be 14 and a half. 14 is very bad luck in China.
Oh, okay. Well, that's good to know. I'll apply that to my lab.
So we always go, when I'm doing that, I always go 14 and a half. I never go to 14.
हाँ वो बैन स्टैंड खुला है ना इसीलिए अभी कम हो जाएगा
Little test.
Okay. Take shoot.
Yep.
Excellent.
Looks pretty good now, guys.
Yeah, pretty good. I don't see the dissection thing now.
No,
Looks really nice. Now the
But
proximal
looks a little bit
calcified
under,
lesion
no?
looks bad.
Yeah, do you think you need post-dilatation?
well, we're going to do an OCT right now to decide if we need to do post-dilation.
So Sam was saying here, that proximal lesion is intermediate. So I think it'll be interesting. You can kill two birds with one shot and see what the diameter is of the more proximal lesion, or potentially you can do a physiologic assessment.
For proximal lesion, we can check by FFR.
I think we're planning not to do the proximal lesion. On multiple views, it looks to be maybe 30%.
Yes.
Sanjay and I have looked at the diagnostic procedure in detail before. And our feeling was that we did not want to address that. That's probably better addressed with statins and dual antiplatelet therapy. Okay, get some.
John, you think your eye better or your OCT better?
I think OCT is better when I have somebody who can interpret it behind me. If this was me, I would have some doubts.
Fine. That's perfect.
So we're in a distal vessel here,
Yes.
and this is an automatic pullback, right?
Oh, just fluoro. Perfect. Okay.
Happy there?
Yes. Just tell us when to eject. Yes. Start.
Sanjay, I'm going to pull this catheter back.
Yes.
This way. Okay.
Yeah, this will require
Okay,
post-dilatation.
I try to explain the results. Here is the distal portion, right? So it's a distal edge. Some incomplete apposition in the distal edge, right?
Okay, we'll fix that.
Yeah, and then the other portion, yes, lumen diameter is enough. Yeah, there's some more position, yes. Here is in the big, yes, plug. Yeah, right. And then some clock. And here is the proximal portion. That's
Yes,
just a branch.
diagonal branch.
Yeah.
Yes.
Here should be the branch. So,
So, TAC, what's the
one
OCT say?
slot is
So-
yes, jailed, but it no problem, right? Yes, two slot. Yeah.
So you're protruding your diagonal?
Here is a diagonal, right? I'll try to show you. Here is the diagonal, right? So you can identify the longitudinal view here. Can you see here? The arrow
Red
here.
arrow?
Yep.
At the bottom?
Here is a diagonal, right?
Position of the
So
stenosis is higher.
the 1 or 2 stroke
1
is
millimeter below
just,
the
yes,
correct
a little bit proximal, but it doesn't matter because it's a good branch, big orifice here. So, and the MLD
By short
is,
no quantum balloon layer.
Can you show us the site of intramural hematoma just after a pre-dilatation? This is the place. This is the place.
this might be the plug, right? Here.
Yes.
Here is, you can identify the crack here, and the big, huge plug, fibrolipidic plug, right?
8 no laiso hoga.
So, yeah, MLA site, right, here is the proximal site. If you adjust here, we can identify the MLA site, but there are no significant stenosis. The result is very wonderful. However, you can identify the red color. This is the incomplete apposition, but here is the branch.
Yes.
So no problem.
Okay.
No problem at all, right?
How about the proximal
And
lesion?
just distal to the branch, here, apposition is wonderful. No problem. And the other color is almost all white. And the distal portion, here is a little bit difference of the diameter, right?
Yes.
Even in angio, we can identify, right? So
Yes.
that's the reason why we can identify small incomplete apposition, but only two struts, so might be okay. So generally speaking, it's a wonderful.
Okay, thank you.
Right.
Thank you.
I try to show you the 3D, right? This is an stent apposition. You can identify the red color here, only one
Branch.
cell, yes. And 3D navigation. And so you wanna, yes, this way, yeah. From proximal to distal, you can identify the branch, diagonal branch here, right? So you can identify the white color, strut is almost a white color here, and only one strut red, but it doesn't matter. Here we can identify another branch, and this is the edge of distal edge, right? It's okay. Any question about the OCT?
Actually, Professor Akasaka, Malcolm here. So I'm really enjoying your description here. I think we're all learning a lot, and these images are just absolutely fantastic. However, I haven't really heard you talk about sort of quantitative measurements, and I'm just curious, do you place any importance on the MLA as a ratio of the reference cross-sectional area?
Yeah, if I put the cursor here, proximal difference is here 2.5, and distal also the 2.5, and here is 2.32. The percent diameter stenosis is 7.5. We can identify the MLA by the lumen profile here. It's a demonstrate mean diameter. Then compared with proximal and distal difference, here is percent diameter is only 7.6. It's unacceptable. We don't need to dilate much more.
Do you have so what would be your threshold for recommending post-dilation? And it seems as though you're talking about diameter stenosis versus the cross-sectional area.
Yeah, cross-sectional is much better. If you want to have a cross-sectional area, you can measure here using a measurement, lumen counter. Here is 4.87, right? And here might be the 5.07, and here is 4.26. So it might be 85 to 90%. So it might be okay.
So can you evaluate the angiographic lesion that we saw before the diagonal bifurcation that was looking intermediate in the majority of the view and we decided not to treat? So can you measure and do you use that as a information ever to decide whether you are going to treat that lesion or not?
In our daily clinical practice, we try to use an OCT before procedure to decide the landing zone clearly, and so the procedure is a little bit different. So we try to identify very normal looking, but if there are fibrous plaque, it might be okay. So the best position is the normal looking, but fibrous or fibrocartific is very stable. If the landing zone is lipidic, there are some risk of lead stenosis. But in this case, the proximal side, we can identify here, right? Here you can identify the fibrolipidic plaque, but the quadrant is less than 1 quadrant. It should be okay, right? And here is a distal portion, almost fibrous plaque, and we can identify the 3 layer here. So,
Professor Akasaka,
yes.
Mauricio Cohen, so I'm going to emphasize the question that Dr. Quintor Sangvi asked. Can you go more proximal with your cursor, because there seems to be a lesion proximal to the stented area.
Okay, right.
And that's what we wanted to know, what the cross-sectional area was. A little bit more? I think it's a little bit more proximal.
Wait a moment, I try to, yes.
At around 50 mil, at the 50
around
millimeter.
this portion, right?
Yeah.
We can identify the branch here.
Yeah.
Yes, yes.
I think that area that you just passed at around 50.
So the MLA, you can identify the mean diameter here, right?
Yeah.
So I try to move here is a 2.1, 2.1.
And what's the MLA there? The cross-sectional area.
Okay, wait a moment. Right. I try to change. Around 3.6. Around 3.6.
3.6.
Yeah.
Would you, in a proximal LAD, would you consider that? I mean, the magic number we were taught was 4. I know that things have changed more recently.
Yeah, she's a 73-year-old.
If you
She's a
think
very
about
frail woman.
this-
I don't know if I would go by MLA in her, and if I was going to go after something, it would be physiology.
I agree with you,
diameter.
John. I agree with you, John. I think physiology is a much better way to evaluate than the magic number of 4.
Yeah.
Yeah.
But, I mean, it should be 4 in an NFL linebacker and 4 in a, 5'2", 110-pound woman. I'm not so sure that really holds up.
Correct. So that's why physiology is a much, it's a much better test.
Yeah, I think physiology is much better than the area.
Occasionally, you actually have to talk to the patient and find out if they have angina.
Can you show us the calcium? We see a lot of calcium in the
Calcium
angio.
is here. You can identify the very clear border. So behind this, there are lots of calcium, right?
And we saw the calcium in the angiogram as well, right?
Yes.
So the calcium is not 360 degree, just only 90 degree.
You can identify here the very normal looking portion, right? So calcium is not 360 degree, but
So what's
here is the minimum lumen site.
And what's the area there? 3.5.
3.5.
Yeah, 3.5.
3.5.
If we listened to Quinto yesterday, if we want to do a PCI, we're using the IRIS or OCT criteria. But if we do the FFR, then we're using...
Indication for PCI, we always decide by physiology. If there are ischemia, we have to treat, but no ischemia.
But left main is different, right? Left main
is different, right? So if you think about here is the proximal reference, the area should be, wait a moment, 8.7, right? So huge difference compared with this portion. The diameter is 2.5, here is 3.3, right? So if you try to this portion, the reference might be around here. We can identify some fibrous plaque. Here much better, 3.3. So it's depend on the ischemia, right? If there are ischemia, we have to put another stent from here to here, some overlap across the diagonal. So I highly recommend, if you doubt about this region, physiology is the best to decide to treat or not treat.
Going back to the stent, what diameter stenosis will you go dilate more? The threshold, it was 7%, but would you dilate if it was 10% or 15%?
It depends on the condition, but we try to get less than 10% as possible as we can, because if there are some eccentric calcium, if we dilate more, we have some risk of rupture. Yeah.
Absolutely.
So, Sammy, if we don't have an OCT, would you just look at an angiogram? I think I will post-dilate it in this case. Would you?
With LAD, I always do, because I always, feel that LAD is bigger than what our eyes tell us. And so I go quarter size up and see the growth of the balloon and see balloon and post-dilate.
I got to tell you though, Sanjay, we pre-dilated with a 2.5 balloon at not very high pressure, and we had that hematoma that Mauritius pointed out. So I don't think I would have the guts to take this to a very high pressure. We deployed at 15 atmospheres, and I think that I would be satisfied right now. I think it would be a lot safer than trying to go in there with a non-compliant balloon and going up to 18, 20 atmospheres. Tejas has always said Indian arteries are very different than Western arteries. And I think routinely we'll come in here and bang this up with a 275 to 20 atmospheres and get away with it. I'd be really frightened just the way she behaved when we just pre-dilated it to do something that crazy.
True. I think, the ethnic difference, I agree with you.
So, should we take one more shot?
Stent is good.
So, do you want to take a final shot?
Yes.
Which one do you want?
Remove wire?
Yeah, I'll take it. Okay, let me take the wire out. Okay, ready?
Fine. So we'll go to reader.
Okay.
Right check.
You want to go LAO to get down the setting? Or you want to change out the right?
But
okay.
You want to cut this, no? Fellow cut karo side. Knife. Or a scissor. We'll cut this.
Okay. Do you want me to take this out?
We'll exchange one of them.
Okay, yeah.
So I'm just removing this sleeve.
If you could, Sanjay is going to show you how he adds about 3 centimeters to the working catheter length.
No, don't. You may be here. Please leave it.
Okay.
This is okay.
I don't want you to cut yourself. You have work to do today.
Yes.
So Sanjay and John, is this a feature of the launcher catheter or this?
Yes, this is the launcher catheter.
No, I understand that, but this white portion you only see in the launcher, you see in other catheters as well.
You also see it in the cordis catheters. If you look at the cordis catheters, instead of white, it's a yellowish color.
Oh, okay. Yes, and now I remember. Yes, we use launcher catheters in my lab almost exclusively.
Yeah.
It's just markers. So
it's okay. Fine.
Sanjay bhai, is that correct that on that white portion of that polymer is just used to put the size of the guide catheter, right? It's just they imprint those numbers.
Yeah.
It does not really have, and the wire mesh in the guide catheter comes all the way to the green hub. So the 3 layers of the guide catheter and the middle layer, which is a very intricate engineering of wiring that allows that reverse weep control. It extends all the way to the green part. So.
Got the wire, Sanjay?
Yes. Go to LAO.
LAO frame? All right, just LAO. LAO. Let me come down.
Go with that. Little more? Little more?
A little bit more, yeah.
Little more? Yes. Okay. Give baby J.
You think we're going to need a tumor wire?
Yeah, baby J wire will work here.
So another option could be
Baby J will, I think, go.
Yeah, I think so.
another option could be just using a pigtail catheter and open the pigtail towards the
Most
descending.
into baby J wire will be able to negotiate.
I think with a hydrophilic wire, we'll be able to get up and over.
We can pull back the guide catheter a bit more and then we can push the wire and that may help.
So there's a many different rate.
Right.
Okay, so to the descending, which one is preferred, Sanjay?
I mean, the other thing we could use is a lemur could also do this too.
Will loud dilation? एमाथे नहीं जाना है. Okay, fine. Left eye. Baby J.
Do we have a
Loud.
what's it?
Okay, you rotate. I will
Okay,
push
I'll
here.
rotate the catheter. You want to
Stick little more. Yes.
a little higher?
Is there any spasm?
The lower part of the arch saddle. John, it seems like you're in the lower part of the arch saddle.
Yeah.
Maybe you can come back
I'm coming
way
back
much
some.
higher.
I think there's also tortuosity up above. You didn't see us when we first started the case, but I'm having a hard time holding the torque in that direction.
Sometimes a big breath even brings you down to the descent.
Yeah.
Swash lounder.
You think every view is better?
Yellow.
I think so. To get down to the center, it's better. I'm coming all the way up here now.
Yes, this will work.
Yes, that
Right.
Yeah. Sanjay's catheter has absolutely no torque control.
Yeah, I think that Kintur's idea of bringing a pigtail and
Might
then
be the way to
orienting
go.
the pigtail may work.
Yes.
John Tejan here. Go to the aortic valve and deflect it up. It will go up that
Oh, you're
way.
talking about that? Okay.
Yeah.
Yeah, the claret technique might work.
Yeah.
This one is too flimsy for that.
She seems to have some calcium on
This
the
wire is quite flimsy for that. If you want to do that, you have to use stiff angle glide.
You can take a double length Terimo and then you can do
A
that.
little bit more in. Yes. Okay, now torque.
So set wire right. Once.
Another option could be steerable angle glide wire. So that
Yeah,
also.
or a Lima, just a Lima diagnostic.
Yeah, but the problem is that the Lima diagnostic will not be longer than the guiding catheter. So the
No,
pigtail.
but I'm saying just to get down.
Yeah,
Then
no,
exchange.
yeah, but then exchange. But the pigtail is just long.
Actually,
I mean, it's
John,
just like 5 centimeters longer than the guiding catheter.
actually you have a EBU on the table that will also bring you down if you deflect it.
Okay, we can take tiger
Tiger.
catheter
Okay.
to enter in descending. Tiger. No.
She's feeling it here in her wrist.
There's also a lot of, apparent calcification in the brachiocephalic area.
Yeah.
And there was a severe tortuosity when you advanced the wire the first time.
Yeah.
Everything
And
is playing against that, so.
You also have a subclavian that looks like a roller coaster.
Yep. I think in this kind of elderly female, using an end-hole catheter and trying to just torque it and advancing glide wire, I find it a little bit more likely to cause trauma versus using like a J wire and a pigtail to just open the curve.
Talk you this way.
Little more deep.
A little bit more deeper.
Yeah.
Sanjay, as much as I'm doing this, it's not moving.
So Sammy, you think you will do it from the left next time?
Yeah. Yes.
There we go. There we go. Tiger always works.
You want to exchange over this?
You advanced tiger.
In Miami, the tiger, we call it El Tigre.
Yes, there's a lot of calcium.
Yeah. She's not going over time. No, okay.
Go. Yes, yes.
At the time of bringing the guiding catheter,
I think at this time, if she takes a deep breath in, it will go down.
Would you put a stiffer wire across the tiger?
Yes, but once it is
We got to get down.
You gotta get down there.
There we go. Now we can put a stiff wire in.
El Tigre always works.
Okay. Long.
So this tortuosity may work against your length calculation.
Yes.
Charles, we are taking M-plus exercise.
Okay.
Now multi-purpose work.
Yeah, no, I just. What wire is this?
So what kind of wire you putting in?
M-plus extensifier.
And this feels like a Terumo wire.
This is Terumo wire?
Yes.
Yes, Terumo.
Terumo stiff shaft.
Stiff shaft, SS, okay.
You want us to work on the iliacs?
Still more. Okay.
Taking a renal stent across that curve might be a challenge, right?
Yes.
I think despite the tortuosity, looking at the length of that tiger, where it was reaching and the amount of tiger length that was outside, I think your guide catheter will
have enough.
I agree, Kintu.
We certainly hope so.
Now, John, what's your strategy now thinking ahead of, are you going to direct stent or are you going to predilate the vessel?
I usually like to pre-dilate renals to get a feel for the size and compliance. I think the last thing you want to do is to have to put a renal stent in and go to very high pressures.
When you put a filter,
I think that most people wouldn't put a filter in nowadays.
Filters didn't work in the clinical trials, right?
Getting this thing to move down here.
Because
And they tend to make the procedure more clumsy.
okay. See where we are?
Yeah. Okay, we're way down.
Yeah, it's a good length.
Yes.
Good length.
We're in the iliac.
how tall is the patient? John, do you know?
I think it's a 5 feet.
Yeah.
renal.
But I think you are feeling very much discomfort with the catheter movement.
Yes.
Yes.
Let's see. Sanjay, I have
So
absolutely
do you have a wire? Do you have a wire inside the catheter? Because with all the proximal.
I'm having no torque.
I would put a wire there because you're at high risk for for kinking with all the tortuosity more proximal.
Looks.
અથવા તો સેમ આપીશ તો ચાલશે ટોટલ. હા એ ચાલશે. It's okay. Left is fine, right is also very tight.
You want a picture of the right?
Yes.
Guide is not moving.
You want it now? You want to shoot?
To rotate. Okay, we take shoot.
Okay, yeah, let's look at the right.
Again. Oh. Right is also tight.
Are you in AP view?
Yes, this is AB.
You got a big pressure break.
It has engaged to the right ostium.
And there is damping, significant damping is there on the pressure tracing.
Yes.
I think.
We can take the pressure.
Yes, this is pressure is going on. So significant damping.
Okay, the pullback, we can see the pullback.
Yes.
We cannot see a pressure. We cannot.
The pressure basically went down to 40.
All right, we take your word.
Do you want to show that replay for them?
Left.
No, that's okay. You don't need to replay that. We believe you. Tak is making sure you don't miss Tejan.
I'll let you try this, but I can't. I honestly can't torque this thing to the left.
Yes, it's going towards.
Yeah, she's having a lot of wrist pain.
There is king. There is king somewhere.
Yeah.
No, it's king.
Yeah, I know. It's kinked up here. Do you want to take this out and change?
No, it has kinked somewhere.
Yes.
Because
it's kinked right over here. It's kinked right here at the hub. It's kinked right where we.
So then you definitely have to exchange the guide.
Yeah, it's kinked right where we made the cut.
We are planning.
We
can take a Lima catheter or hockey stick.
So the question is, what shape guide catheters would you select? Would you select anything different? And I think GR4 and multi-purpose are the two invariable choice because of that cranial
I don't think it was guide
origin.
catheter choice. I think it was more the
hockey stick.
Multi-purpose. King third guide.
So traditionally a little bit LAO and a little bit cranial
Left to decided, sir.
will get you like perpendicular to the origin of that renal.
Sanjay, you don't think that the right is tighter than the left?
But we have to hook.
What?
Means we will show them.
Okay.
So which renal artery are we addressing today? The right or the left?
Actually, our plan is to hook, do left renal stenting, but both are
very tight.
Both are tight.
So would you consider then treating both on the same day?
No,
I don't think so.
We never do.
Yeah.
We also do not do.
I would not think that that's a good idea.
I don't think that's a good idea at all.
Why it's not a good idea?
I think if you have a problem with one kidney, you'd like to make sure that you don't lose both kidneys on the same day.
So renal artery intervention trials have been negative for two primary reasons. One is patient selection and second is the risk of atheroembolism that's associated with the intervention.
You want to get this down, Sanjay?
And I generally would say if I treat two renal artery, I at least give minimum
We can take Amplaz exercise required.
3 to 4 weeks time
You want to use a stiffer wire again?
prior to bringing back for
Keep
second
like
renal
this.
intervention.
We'll take Amplaz exercise
Okay.
required.
So how you minimize the complication, the embolism?
So the reason for the thrombolism is because, if you look at all the renal artery diseases, mostly osteal disease, and atheromatous plaque distribution and the severity of the plaque distribution in the abdominal aorta is the highest in the entire aortic length. And therefore, when you are selectively engaging the renal artery is the time when you have maximum risk of, that's the time when you have maximum risk of atheroembolism. So, are you already in celiac artery or what? The way the wire is going into the...
Yeah, I know.
Okay. Let me check here.
Okay.
Or we can go a little down.
Is it multipurpose?
Yes. Who's guiding?
I'm pushing it out.
Let me check.
Okay.
If it is renal artery, then we put wire and then we'll slide this guide over that. Let me check it.
See, I don't think you're right.
Yes, we are renal artery.
Okay.
We take suit.
Okay, ready?
I think you are
Does
already...
catheter dampen there or no?
Yeah.
No, but we are proximal to lesion. Here it is not osteal lesion. It's just proximal part of renal artery. And this is a multi-purpose diagnostic catheter actually.
Right.
Over which we have slided 6 French EBU. We want to this time.
You want to fix this?
I think right is more
I think the right is
critical than this.
Hi
You
guys.
can show you the pictures, but the right looks like it's more critically stenosed.
You can slide guiding over this.
This is great work so far. Rajiv here. Just a comment on what Kinter has said about atheroembolization is that if you look at abdominal aortas, all of the plaque is infrarenal. So this is a real advantage of going from the radial as you have much lower risk of atheroembolization.
Let's go top.
So I don't know if everybody heard Rajiv's comment, but the distribution of the atheromatous plaque is caudal to the origin of the renal artery. The more distribution of the severe plaque is on caudal to the origin of the renal artery, and therefore we think that craniocaudal approach or coming from the renal artery, radial artery is much better than coming from femoral artery for renal artery intervention.
Yes, now it will go. Who's whole assembly? Yes. Okay. Now I am removing this. But no, still we have to go there. Little more. Yeah. Yes. No. So I think both renal arteries are critical. So whatever renal artery hooks, we do.
She's having a lot of risk.
The thing is that superior mesenteric artery origin and its relation to the right renal artery is also one of the important things for stenting the right renal artery. If they are very close to each other, then stenting the right renal artery ostium might lead to shifting of the plaque into the superior mesenteric artery, and sometimes you get abdominal ischemia and other pathologies.
Yeah.
Yes.
Okay. Too low, right?
So the patient seems to be having a bit of a spasm in her arm.
Just so that left renal artery or right renal artery view, we see which spine. Previous view?
Next view.
Oh, this. So first and second lumbar vertebra junction.
Right.
Yes. Little up.
Right. A little higher.
Little up. Little. Yes. Here we'll get. Push little.
Yeah.
Okay.
She's having a lot of wrist spasm. A lot of radial artery spasm.
Yes. BMW.
Right.
Yeah, I'm afraid to let this go.
This is okay.
John, I have to tell you, long sheath helps here.
What was that, Tijan?
longer sheath would help in here, right?
Yeah, well, yeah, and she's having a lot of radial artery spasm.
But at the moment there is no scope.
Yeah.
I think you also have a, another problem is at the brachiocephalic level with that calcification and straightening out that tortuous
Yes.
area. So your forward force is not really transmitted.
This really is aortic osteo.
Okay. So we are going to use coronary stent, onyx.
This really is more consistent with renal artery stenosis. This is aortic osteo disease, Kintur. The other one looked like it was a couple of millimeters in. You want to take a picture?
Yes.
So this is the other advantage of coming from radial in this aorta ostia lesion. You can easily park the stent
5 by 15?
to just truly cover the ostia.
We take 5 by 15 onyx?
Yes.
You
want to dilate?
No.
What?
Take it a little faster.
What is the advantage of using coronary stents in renal?
See, I have seen at least in 30% of patients, ours, significant stenosis, even with 6 millimeter and 7 millimeter dedicated renal stent.
We had Tijan.
But so it is our routine practice to use coronary stent, 5 millimeter, and if needed, we can dilate it with 6.
But do the coronary stents have the adequate radial strength
Radial strength.
to withstand
we
the
have
aortosteal?
seen follow-up Doppler, follow-up angio, and excellent results.
But don't you think it will be a bit of an undersizing of the stent? Like
No.
this looks like maybe a 7 millimeter vessel.
You see after the result, you will realize. Give 515 onyx.
We usually use 6, 7 for renals.
So 5 millimeter onyx we are going to use. That will reach up to 6.
5.75.
5.75.
5.75.
But that will be okay compared to restenosis.
What stent?
Compared to stenosis,
You
but
want to use an onyx 5 millimeter.
At least it will be very deliverable. At least that's with all those curves and all, it will go fairly easily, I believe.
I think so. I like to pre-dilate this.
No.
Pre-dilate part 4 nu balloon down.
Can we get like a 4 by 12 maybe?
there will be more risk of, if you do pre-dilatation, there will be the more incidence of atherombolism into the renal vessels.
Not really.
Can we avoid pre-dilatation?
We can avoid. We can do direct stenting also.
But I think it's a good idea to do pre-dilatation.
Go for direct stenting. If
we're going to go for direct stenting?
come across any resistance, we'll dilate it.
Yes, yes.
You know
But
what they say,
I have a
when
feeling
I'm
that
wrong,
pre-dilatation
I'm
would
wrong.
be a good idea here.
Vessels, even after stenosis, there is a good caliber to accommodate a 5 stent
Make both images similar.
without pre-dilatation.
So I routinely pre-dilate renal artery lesions. How about you, Raju?
I normally do also, Kintur, but when I'm wrong, do as the Romans do. Right?
Yep.
Don't Google it is making 2 images similar.
In this case, since we are using a coronary stent, I suppose pre-dilatation might have been an option, because I also routinely pre-dilate renal artery stenosis. So let's see, fingers crossed.
Just a comment to Kintur. So in the US now, the only renals that we're stenting are 99% bilateral stenosis, and John alluded to that early on. So for that reason, pre-dilation is what we do. But I think for this sort of lesion, bulky plaque, risk of embolization, and I think direct stenting seems very reasonable. I don't see any calcification there. So this seems like a good approach, in my opinion.
Yeah.
Fine.
So fine.
Fine, it has crossed.
Just little, okay, it's perfect.
Yes.
Little back, stand, pull stand,
Slight pull back.
pull.
Yes. A little bit more.
Or a bit more.
Little more.
The catheter maybe needs to be pulled slightly as well, maybe
Yes.
just a wee bit.
Yeah. No puff here now.
It's
What do you
Little
think?
more?
This looks
No, little more.
little more back.
Little more.
Yeah.
Yes.
So you
Yes, yes, it is the perfect position. Yes.
Okay.
So we take CNA?
Yeah.
It's
That's
perfect.
good.
Yes.
Right there. Take it up.
So we can see this advantage of this craniocaudal approach. If you came from femoral access for this, for example, it would be so difficult.
No.
Stunting.
So that's another thing always to monitor if patient is having pain, you don't want to expand.
That's what I'm saying to him.
It's okay, fine.
She expanded very nicely.
Let's take a test.
During pull, you push guiding.
Yeah, I just...
To pull back the stent and post dilate again?
Yes, depending upon result.
You could potentially flare the...
Okay, we can see even with this.
You can, yeah, you can potentially flare the osteal. Yeah.
Okay, so reasonably good.
Reasonably good.
How hard did you go?
I would be really concerned in post-dilating that.
Can't do it.
We can take 6 milligram.
I kind of agree with you. When you were dilating this, she was having pain.
Yep.
Was she having back pain when you were dilating?
Make bigger.
So we can definitely use the same balloon to maybe flare the ostia a little bit, but that's about it. I don't think we want to post-dilate with a higher size balloon.
Flaring is not an issue. We can come back and we can give pressure again. And we can take 6 millimeter also for post-dilatation if required.
Is a 5 stent?
Yes, okay. We have come back.
Was she having back pain?
That is okay. 20. It's fine. Okay. Push.
It's not that easy.
I'm just explaining because, okay. Now push whole assembly.
Okay.
So this is like a bed.
Yeah.
Little more.
Yeah.
Little more. Fine.
Balloon is inside
Fine.
right.
Now we remove balloon.
Okay. You down?
Yes, we remove balloon. It's okay. Maximum make कर दो.
Yes. Other renal after 1 month. Today? No. It should not. As because if we do.
We have in United States something called osteal flash. It's a osteal flash balloon to flare the aortosteal stent studs. Works really well for this particular area.
Very good.
I don't think post-dilatation is required.
I wouldn't post-dilate this.
You want to post-dilate?
No, I don't want to post-dilate.
No, it's very good.
It's a very good result.
Yeah.
This looks really beautiful.
Okay, so remove eye.
Right, Dr. Sanjay, if
So
we can
one
go
of
on to
the
the next room.
I would suggest one thing is just do a full nephrogram. I don't know if you, we don't see it, but I don't know if you see all the way to the branching.
You want full program? So
you got to decrease MAC.
DMAC.
So Kintur, you have more experience with this. Renal parenchyma looking like modeled.
Like he wants to have the whole kidney on.
Okay.
Like that.
Kidney button.
Right, ready?
Yes.
Okay, can't do it, no perforations.
I think that's a good practice to have every time after finishing renal.
So we are done?
Yeah.
What is the importance?
Next, so we are
You want
switching
to take
over
this out
to
over
other left.
Take this out over the wire.
What is the significance?
Thank you, Dr. Coppola and Dr. Sanjay.
Thank you.
Excellent job, guys.
Thank you.
Thank you.